ಇದು ವಾಪಸ್ ಹೋಗ್ಬೇಕಂದ್ರೆ ಆಲ್ಟ್ ಏನು ಹೇಳಿದ್ರು ಮತ್ತೆ PPT
ಇನ್ನೊಂದು ಸ್ವಲ್ಪ ಮುಗಿ ಕೊಡ್ತೀವಿ ವಿಶೇಷ ಇದೆ.
ಇವಾಗ ನನ್ನ ಕ್ಲಾಸ್ ಇದೆ.
ಈಗ ಹೋಗೋಣ 10 ನಿಮಿಷ.
Good morning, students. Good morning.
Good morning, ma'am.
Good morning.
Yeah, how are all of you? How are all of you?
Fine, ma'am.
Fine. Okay, Chandra Reddy, are you here? Just on your video. Chandra Reddy. Not there, Vinay?
Yes, ma'am.
Yeah, how are you? On your video,
fine.
I want to see you people. It's long back. No? Get up from the bed or not? Got up from the bed or not? Kirtan? Anusha? See, people are not attentive. Arun? Yes? If you are not alert and attentive, you will be the loser, because you have to face the exam, you have to understand the topics. Yes or no? By this time, 9 o'clock class starts, you should be very much attentive as if you are in the classroom. Okay? Even though it's online, you should consider it as an offline. Okay? And be very attentive. Okay? Yes, anyway, we will start today's class. Okay, that is again the mechanics of breathing. In that only I will be discussing today about the alveolar surface tension, compliance of the lung and chest wall, okay, and surfactant. These things we will discuss today, and they are very, very important, and you need to understand them. They are somewhat difficult topics to understand. Okay, once if you are understood, it will be easy for you to read and recall. Okay, so let us commence with alveolar surface tension. So as you all know, the child will take first breath immediately after birth, isn't it? Immediately after birth, child will take the first breath and lungs will expand. Okay, and at the end of expiration, the lung has a tendency to recoil back. Always lung has a tendency to recoil back, and the chest wall has a tendency to recoil in opposite direction. Okay, but in health, these two forces balances. That is, the tendency of the lung to recoil back balances with the tendency of the chest wall to recoil in opposite direction. Okay, so the tendency of the lung to recoil back is governed by two forces. Okay, that is the recoil of elastic tissue of lungs and surface tension with the alveoli. So lungs are the elastic structures, you know. So if you expand a rubber, okay, its length will increase up to within physiological limit. If you expand it beyond the physiological limit, it may tear or it may lose its elasticity and becomes loose. Okay, so lungs are also like that. They are also elastic tissues. Okay, they have a capacity to expand. Okay, and recoil back within physiological limit. So if they are expanded extremely beyond limit, they will lose their elasticity. So lungs are exactly like a rubber tissues. Okay, they are elastic tissues, and these force will help in recoiling back of the lung after inspiration. During inspiration, lungs will expand. Okay, then the surface tension with the alveoli. So alveoli has a thin layer of fluid. Okay, so in between these fluid and air interface, the surface tension will develop. Okay, so this also help in recoiling back of the lungs. So these are two important forces which helps in recoiling of lung, that is the elastic tissues of the lung and surface tension in the alveoli. Okay, so this diagram shows, as I told you, lungs have the capacity to recoil back, a tendency to recoil back, and chest wall has a tendency to expand. So what happens if you open the chest? Lungs will collapse. Okay, or if you puncture the intrapleural pressure cavity. Okay, intrapleural pressure becomes zero, means the just will expand. Okay, just will expand. So always they are stuck together and there is a negative force. Intrapleural pressure is a negative pressure. Okay, that maintains the lungs and chest wall in a normal position, normal size and shape. If any abnormality in this may lead to the collapse of a chest, collapse of the lungs, and abnormal expansion of a chest wall, leading to the barrel shaped chest. Okay, so now coming on to the, what is surface tension? Surface tension is due to the intermolecular attraction between the surface molecules. Okay, it is due to intermolecular attraction between the surface molecule. It tries to reduce the surface area and collapse the lung. So surface tension, it is because of the intermolecular attraction between the surface molecule, and it tries to reduce the surface area and collapse the lung. Okay, it should be reduced, especially during expiration. So during expiration, what happens? Alveoli will become small. Diameter of the alveoli will become small. So during this time, the surface tension should be reduced. Otherwise, the alveoli will collapse. Okay, so it should be, surface tension should be reduced, especially during expiration. Otherwise, the alveoli will collapse. So according to Laplace law, you know this, I think in your 10 plus 2 classes, isn't it? What is Laplace law? P is equal to 2T by R. Okay, where P is the distending pressure, T is the tension or force. Okay, and R is the radius. So this Laplace law holds good to any spherical hollow structure like alveoli, stomach, okay, bladder, okay. So those structures, spherical hollow structures, will follow this Laplace law, that is P is equal to 2T by R. So that means P is a descending pressure, T is a tension, R is a radius. Why it is important in alveoli? Means during expiration, what happens? The radius will reduce. Yes or no? Okay, radius will reduce. So if we keep P as constant, Okay, pressure as a constant. If T is not reduced along with the radius, the lungs will collapse, isn't it? So when radius is reduced, tension also should reduce to keep the alveoli patent or expanded. You are understanding this? Okay, so Laplace law holds good to our alveoli. So whenever R is reduced, when P is constant, T should be reduced to keep the alveoli open, okay, or prevent the alveoli in collapsing. Okay, so this diagram shows the same thing. So P1 is the pressure in the alveoli during expiration. During expiration, alveoli will become small. Diameter of alveoli will be small. During inspiration, it will be more. Okay. So Laplace law is 2t is equal to PR. So P is equal to 2t by R. So for same, if tension we keep constant, P1 will be greater than P2. Isn't it? If tension is constant, that is 2t by R1 is greater than 2t by R2. That means tension in the P1 is more. So that's why I told you surface tension should be reduced during expiration to prevent. Already the diameter is small during at the end of expiration. So if further the surface tension is not reduced, the alveoli will collapse. Okay. So this is the importance of your Laplace law. Okay. So now coming on to the pulmonary surfactant. So in our lung there is one substance called as surfactant that reduces the surface tension. Okay. So the surfactant is nothing but a mixture of protein lipid complexes. Mainly it has a lipid called dipalmitoyl phosphatidylcholine, or it is called as DPPC. So this is the major component of our surfactant. It is a mixture of protein and lipids. Okay, so important lipid in this is dipalmitoyl phosphatidylcholine, that is DPPC, and it also has other lipids like phosphatidyl, glycine, proteins and carbohydrates. Okay, and this surfactant is produced by, I told you already this in my introductory classes, it is produced by type 2 granular pneumocytes. So our lungs has type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes help in exchange of gases, and type 2 pneumocytes are granular pneumocytes. They secrete the substances called surfactant, and the function of the surfactant is to reduce the surface tension and to prevent the alveoli in collapsing. Okay, so this is about the pulmonary surfactant. Okay, so what are the other functions of this surfactant is surface tension keeps the alveoli dry and help in exchange of gases. Okay, because of surface tension it keeps the alveoli dry and helps in exchange of gases, and surfactant helps to prevent pulmonary edema by reducing the surface tension. Okay, usually the pulmonary capillary pressure is around 5 to 8, around 10 mm of Hg, but whereas the colloidal osmotic pressure is around 25 mm of Hg. So this colloidal osmotic pressure is always a sucking pressure. Okay, so it draws the fluid from alveoli to the blood, and which keeps the alveoli always dry, and that is needed for normal exchange of gases. If there is a edema or fluid accumulates in the alveoli, exchange of gases will not occur properly. Okay, so this to keep the alveoli dry is very important for normal exchange of gases. So in the diagram it has shown type 2 cells, that is type 2 granular pneumocytes, which secrete surfactants. Okay, and it is removed by alveolar macrophages. Okay, so you can make out here the it forms a layer. Okay, so this cell will secrete the surfactant, and this surfactant will form a layer in the inner wall of the alveoli. Okay, the inner wall of the alveoli, it forms a layer, and there is a fluid actually and air here. So the surfactant is in between the thin fluid layer and the alveoli and the air. In between it forms one more layer and reduce the surface tension. Okay, so this is about the pulmonary surfactant. So why it is important? Why are talking about this surfactant? Surface active agentic water. It reduces the surface tension of water and the alveolar wall. Okay, so here you can make out there is a pressure. Okay, so pure water surface pressure is around 72 dynes per centimeter. Okay, whereas normal fluid lining alveoli without surfactant, if I told you already, the normal, there is a fluid layer which lines the alveoli. So if there is no surfactant, it leads to the pressure of 50 dynes per centimeter. But normal fluid lining alveoli with surfactant, if there is a surfactant, it reduces the surface tension to around 5 to 30 dynes per centimeter. So with this you can come to know that surfactant is a substance which reduces the surface tension from almost 70, 50 to 5 to 30 dynes per centimeter. Okay, that's why it is important, and its function is more during expiration for preventing the collapse of alveoli. Okay, so then factors affecting surfactant. So in which condition the surfactants level will decrease and which condition surfactant level will increase. So in long-term inhalation of 100% oxygen, occlusion of main bronchus of the lung, occlusion of one pulmonary artery, smoking, okay, cutting both the vagus nerve, all this condition will lead to decrease in surfactant secretion. And in which condition surfactant will be increased? In the increased thyroid hormone, like thyrotoxicosis, glucocorticoid secretion. Okay, so you might have know that if in case of a premature delivery, okay, premature delivery lungs will be immature. So if because of any complication, if the gynecologist has planned the premature delivery, they will give the injection of glucocorticoids to the mother. Okay, 12 hours or 24 before the cesarean section or delivery, they will give the injection of glucocorticoids so that the fetal lung should be matured. Okay, and absence of GM-CSF. So these are some of the conditions in which affect the surfactant levels. So one more applied aspect you must know here, that is the hyaline membrane disease or infant respiratory distress syndrome. IRDS is infant respiratory distress syndrome or hyaline membrane disease. So this occur usually in a premature born babies. Okay, premature born fetuses. Okay, where the lungs are not yet developed completely. Okay, so the surfactant has not produced, or surfactant is in a very minimum amount. So the alveoli will collapse at the end of expiration, and that leads, if there is a severe disease is severe, it may lead to the respiratory distress syndrome, and immediate admission and ICU and oxygen supplementation is needed for the fetus, and if it is very extensive, the fetus may die also. Okay, why it is called as hyaline membrane disease? Okay, in this condition a thin hyaline membrane will be formed in the alveoli, hence it is called as hyaline membrane disease. And one more applied aspect about the surfactant is patchy atelectasis. So usually this occurs. Atelectasis is a collapse again, collapse of the lung. So this occurs usually in the persons who they have undergone the cardiac surgeries. Okay, and they have taken the artificial respiration. In those conditions, this patchy atelectasis may occur. Here also the same thing, the alveoli will collapse because of the loss of surfactant or less amount of surfactant. So this is about the surfactant. Surfactant is a very important topic for you and very commonly cut short note for you. Okay, so you have to write from where it is synthesized. Okay, what is its function, okay, what is its composition, okay, and what are the factors which increases and decreases the surfactant, and some some two three lines about the applied aspects, especially about the infant respiratory distress syndrome or hyaline membrane disease. Okay, so you read about these things. This is a very important topic. Next, coming on to the compliance. Okay, so compliance is nothing but stretchability or distensibility. So as you know, the lung and chest wall both are the elastic structures. Okay, so we can measure the compliance of the lung and chest wall together and compliance of the lung alone. Okay, so now coming on to the compliance of the lung and chest wall. So what is the definition of compliance? The definition of compliance is the change in the lung volume per unit change in the airway pressure. Okay, so that is the unit change in the lung volume per unit change in the airway pressure. So it is given as dV by dP. Okay, so it is the distensibility of the lungs and the chest wall, and it is expressed in liter per centimeter of water. Okay, so compliance is given in liter per centimeter of water. So volume is given in liters and pressure in centimeter of water. Okay, so this is the definition of compliance. That is the change in lung volume per unit change in airway pressure is called as compliance, and it is expressed in liter per centimeter of water, and compliance is given by the formula dV by dP, where V is volume of the lung, P is the airway pressure, and that symbol is the symbol of difference. Okay, so the compliance of the lung, and if you measure the compliance of the lung and chest wall together, its normal value is around 0.13 liter per centimeter of water. Okay, 0.13 liter per centimeter of water. So for every 1 centimeter increase in the pressure, 0.13 liter of air enters into the lung. That is the meaning of this. Okay, so the compliance of the lung and chest wall is together, if you measure, it is around 0.13 liters per centimeter of water. Then if you measure compliance of the lung alone, okay, then it is around 0.22 liters per centimeter of water. That is, if we measure the compliance of the lung alone, it is almost twice that of the compliance of the lung and chest wall together. Why it is? Because the lung is a very much elastic structure. Okay, and here the elastic fibers are arranged in a very special manner. Elastin and collagen fibers are present in the lung, and they are arranged in a very special manner, like your socks, the socks you will wear. Okay, in that the whole socks you can stretch, but each fiber you cannot stretch, isn't it? So lattice, that is called the lattice arrangement. Okay, the arrangement of a fiber is in such a way in your stocking which you wear is whole the socks you can stretched but not the each fiber. Same type of arrangement will be there in our lungs also. So lungs will expand altogether because of the presence of these elastin fibers, and hence its stretchability or compliance is double compared to the compliance of the lung and chest wall together. Okay. Now coming on to the measurement of compliance, how they have measured, what is the compliance curve. So in the diagram you can make out here. So pleural pressure has taken in centimeter of water in the x-axis. This is the intrapleural pressure, which is always in a negative, and here the lung volumes, change in lung volumes, that is in liters, which is taken in the y-axis. Okay. So this is the curve of inspiration. So they have recorded after each the person is allowed to inspire, and the recording of pressure instrument is attached to the spirometer valve, and for each inspiration about 500 ml of inspiration they have measured the pressure, like they are going on measuring the pressure for every 500 ml, and they have plotted the graph. So when they have plotted the graph, what we can see here, okay, when there is a lung volume is less, that is minimum, the pressure is also less, isn't it? And inspiration and expiration, we have not got the same wave. Okay, so inspiration is a different curve, and expiration we have got the different curve. It indicates that for same 500 ml during inspiration the lung volume is less, but for same 500 ml during expiration the lung volume will be more. You are understanding? For same pressure we have the same more amount of more lung volume during expiration, whereas less in the inspiration. Okay, that's what it is showing. And if our lung would have been a perfect elastic structure, okay, perfect elastic structure, then we have got this linear relationship, the dotted line what you are seeing. Okay, so for every increase in the pressure there is a linear increase in the lung volume. So if our lungs would have been a perfect elastic structure, we would have got this linear line, but it's not, we have not got the linear line. Our inspiration curve is somewhat concave, and this is also okay. So this loop is called as hysteresis loop. Okay, so the relation between the intrapleural pressure to the lung volume is not linear. This indicates that our lung is not a very perfect elastic structure. Okay, so this is about the this graph. So what you can inference, what is your inference by this experiment? So there are two different curves according to the different phases of respiration here. So the it has a inspiratory compliance curve and the expiratory compliance curve. Okay, it this graph shows the capacity of the lungs to adapt to the small change of intrapulmonary pressure. So if there is a small change of intrapulmonary pressure, our lungs has a maximum capacity to adapt, and compliance is seen at low volumes, that is stretchability is more at the low volumes. Okay, and because of difficulty with initial lung inflation, and at high volumes because of the limit of the chest wall to expansion. Okay, so compliance or stretchability we need more at the low volumes, because initially there will be difficulty with initial lung volume inflation. At high volumes, that is at the end of the inspiration, because of the limit of the chest wall to expand. So actual compliance or distensibility we need at these points. Okay, that is at the beginning and at the end. And the total work of breathing of the cycle is the area contained in the loop. So work done during inspiration is the area covered under this loop from dotted line to the inspiration, and the work done during expiration we can measure by measuring the area under from this dotted line to the expiratory curve. Okay, so with this we can calculate the work done of breathing, okay, by measuring this graph. Okay, now coming on to the, as I told you, the reason for our compliance of the lung is because of the elastic forces of the lung. Okay, that is elastic tissue which is present in our lung, and the elastic forces of the fluid that lines the inside walls of the alveoli and other lung air spaces. So, the arrangement of the elastic fibers is responsible for stretchability or compliance of the lung, that is the factor A, and factor B is presence of surfactant. Okay, that lines the inside wall of the alveoli and other lung spaces. Okay, is provided by the substances called surfactant that is present inside the wall of the alveoli. This surfactant also will cause the stretchability or compliance of the lung. These are the two important factors which are responsible for the compliance of the lungs. Okay, and why surfactant is more important? That can be explained by this graph. Okay, this experiment they have done in a cat. Okay, they have removed the lungs, and okay, and they have measured for every change in the pressure, they have measured the volumes. So they have repeated this experiment with the air filled lungs and the saline filled lungs. Okay, in case of a saline filled lungs, the surface tension becomes zero because of the saline filled, and there is no action of surfactant here, so we can make the graph has shifted to the left, and both the inspiration and expiration curve are almost the same. That means it has not at all, it has no distensibility or compliance. Okay, so what they have done by adding saline solution, there is no interface between air and alveolar fluid. That means the B forces are removed. Okay, surface tension is not present, only elastic forces of tissues. Okay, and transpleural pressure required to expand normal lung is equal to 3 times the pressure to expand the saline filled lungs. Okay, so here we can know how much important our surfactant in maintaining the compliance of the lung. Okay, that is shown by this experiment they have done in the animals like cat. Okay, then conclusion of this experiment is tissue elastic forces is equal represent the one third of the total lung elasticity, whereas the B force, that is surfactant, fluid air surface tension elastic force in the alveoli, this constitute about two-thirds of the lung elasticity. Okay, the elastic fibers, tissue elastic fibers constitute about one third of the total lung elasticity, and the fluid air surface tension elastic forces in alveoli constitute about two-thirds of the total lung elasticity. Okay, now coming on to the compliance of the thorax and lung together. Okay, so this is the graph showing the compliance of the chest wall. Okay, and B is showing the compliance of the lung, and this curve shows the compliance of the chest wall combined chest lung cage, compliance of the combined lung and the chest wall. Okay, so as I told you, compliance of the lung is twice that of the compliance of the lung and chest wall together. Okay, then compliance of the whole system is measured while expanding lungs of total relaxed or paralyzed person. Air is forced into the lung little by little at a time while recording lung pressure and volumes, the compliance of the lungs plus thorax is equal to half of the lung alone. When lungs are expanded to high volumes or compressed to low volumes, limitation of chest wall increases and compliance of the system is less than 1 by 5. Okay, these things are not so very important. At least you remember the first graph which I told you, that is hysteresis loop. Okay, you go back and read in your books and try to understand. If you have any problem, you can discuss with me. Now, factors affecting compliance. Okay, so what are the factors which affect compliance or stretchability or distensibility of our lung? So compliance decreases in some of the conditions like pulmonary congestion. In case of pulmonary fibrosis, okay, the elasticity will be lost in pulmonary fibrosis and pulmonary edema. As I told you, if there is excess accumulation of fluid in the alveoli, the elasticity will be lost. Pulmonary congestion means accumulation of more amount of blood in the pulmonary circulation, that also lead to decrease in the compliance of the lung. And in which condition compliance of the lung will increase? In case of emphysema, the lung elasticity will be decreased, okay, and the alveoli will be more expanded, okay, and if they are more expanded, they are they are not able to expand further, okay, and more pressure is needed. So already if the diameter of the alveoli is more, because of the loss of elasticity, more pressure is needed to expand those alveoli. That's what happens in the emphysema. And old age, because of the loss, decrease in the elasticity, as old advances, the compliance will increase. Okay, so these are some of the factors which affect the compliance, and compliance of the lung alone. Okay, so factors affecting only the lung compliance. Okay, what are the factors which may affect the lung compliance? So lung volume. So individual with only one lung, is if the individual has having only one working lung, or one lung has been removed surgically for any reason, okay, then the compliance of the lung will be half, obviously, because of the lung less lung volume and phase of the respiratory cycle. Okay, so compliance of the only lung depends on the inspiratory phase or expiratory phase. Okay, and the effect of gravity. Effect of gravity, the stretchability is more at the basal part of the lungs. Okay, if a person is standing straight, okay, the stretchability is more at the base of the lung, okay, compared to the apex of the lung. That is called as effect of gravity and surface tension. So these are some of the factors which affect only compliance of lung alone. Okay, and what is specific compliance? Specific compliance is nothing but compliance per functional residual capacity. Why it is important? In children it is important, because in children the lungs are very small. Okay, lungs will be very small, and FRC, if we even though stretchability will be normal, if we measure the compliance, we may get the less. Okay, because the size of the lung itself will be very small. Hence, in those cases, we have to calculate compliance per functional residual capacity. Okay, in case of again the patients whom the one lung is removed, we have to calculate their compliance by this formula, that is compliance by functional residual capacity, that is called as specific compliance. Okay, so to summarize what all we have discussed till now. So these topics are not very interesting, but they are very difficult and dry topics. Okay, so you have to read many times to understand these topics. Okay, So my suggestion is today only you go back and read this topic, whatever textbook you are having, okay, and make a notes. And if you have any problem, again we can discuss, okay. Then the lung, to summarize, what is lung compliance? It is change in the lung volume for each unit change in the intrapulmonary pressure. Okay, and the diagram of the lung compliance, we will get two different curves according to the different phases of respiration. As I showed you in the diagram, it shows the capacity of the lungs to adapt to small changes of intrapulmonary pressure. Okay, and what is the causes for compliance of the lung occurs due to the elastic forces, that is the tissue elastic forces, which constitute about 1/3 of the elasticity, and fluid air surface tension elastic forces in alveoli, that is fluid air surface tension elastic forces in the alveoli. This constitute about 2/3 of the elasticity, and alveoli tries to collapse but they don't because of the surfactant and surface tension elastic forces. And surfactant has a mixture of lipid and protein, carbohydrate and calcium ions. Okay, so phospholipids dissolve unequally in a fluid lining the alveolar surface, that decreases the surface tension. So surfactant is nothing but the mixture of phospholipids. Okay, so it dissolves unequally in a fluid lining alveolar surface, and that decreases the surface tension. Smaller alveoli has greater tendency to collapse. As I told you, the fear of collapsing alveoli is more at the end of expiration because diameter is less. Okay, till now we have discussed these things. Okay, now coming on to the measurement of work done during breathing. Okay, so lot of work has to be done for breathe. Okay, so air has to undergo many resistances. Okay, air, it looks very simple, we are continuously inspiring and expiring, but the our air to enter, it has to undergo many resistances. Okay, so the work done to oppose these resistances is very important. So we have elastic resistances, that is 65% is the elastic resistance, and non-elastic resistance is around 35%. That is because of the viscous resistance is 7%, and airway resistance is around 28%. So airway resistance, there is a formula, you might be knowing this. Force is equal to, what is this? Pressure by resistance. Okay, pressure by resistance. So airway resistance can be given by the formula atmospheric pressure minus alveolar pressure. Okay, airway resistance in the lungs is equal to atmospheric pressure minus alveolar pressure divided by airflow. Okay, so airway resistance, that is R is equal to P by F. F is here airflow. Okay, so atmospheric resistance is equal to, airway resistance is equal to atmospheric pressure minus alveolar pressure divided by airflow. Normal airway resistance is around 1.5 to 2 centimeter of water per second in our lungs. Okay, so now coming on to the factors affecting the airflow resistance. Airflow resistance is inversely proportional to the total cross-sectional area. That means airflow resistance increases when the total cross-sectional area will decrease. Okay, and resistance decreases if the cross-sectional area is increased. So how you can understand? Trachea has a total cross-sectional area of 2.5 centimeter square. Okay, but alveoli altogether has a total cross-sectional area of 11,800 centimeter square. That means alveoli have a enormous cross-sectional area compared to the trachea. Hence, the trachea constitute maximum airflow resistance. That is 80% of the airflow resistance is on the trachea. The air has to overcome the maximum resistance while passing through the trachea, even though trachea has a more diameter compared to our alveoli, isn't it? Trachea has a more diameter compared to our main branches are alveoli, but because of the total, as airflow resistance is inversely proportional to the total cross-sectional area, trachea constitute 80% of the airflow resistance. And you know one more formula, that is Poiseuille-Huygens formula. I think you might have read this, where R is equal to 8 NL by pi R to the power of 4. Okay, where R is the airway resistance, N is the viscosity, okay, and L is the length of the tube, okay, and R is the radius of the tube. Okay, this is the formula called as Poiseuille-Huygens formula. So what is the physiological significance this? So duration of expiration is 1.2 times the duration of inspiration. Okay, normally, because expiration is a passive process and airway resistance is high during expiration as the diameter of airway is decreases. So resistance is directly proportional to the viscosity and length, whereas inversely proportional to the radius. Okay, and so this is, we can correlate this with the bronchial asthma. Airway resistance increases as diameter decreases. I think time is over. We will stop here. Still more I need to discuss about this airflow resistance and other things. I will continue in the next class. Okay?
Okay, ma'am.
All of you go through these things. These are very difficult part of the respiratory system, but very basic parts. So all of you go through. Once again, we will revise in the next class all these things. Okay?
Thank you, ma'am.